how radiology plays. The beginning of wisdom is the definition of terms. What is woman imaging? Is there a man imaging? Is there a woman imaging? Imaging in women is disorders, diseases that are radiologically can be detected or managed. Today, the cell phones are so common. Even a potter uses it. And then with this communication, one should be able to outreach people who are living in the villages, in the slums, in tribal villages particularly, and take care of their health. Wilhelm Conrad Röntgen, he was the first one in 1895 who has discovered X-rays. Since then, several improvements have come up in imaging apart from conventional radiology. So in conventional radiology, what are the things that we can contribute to women's disorders? For example, look at this. There is a nice ball-like calcification in the pelvis. What could it be? It's not a bladder stone. Why is it not a bladder stone? It is eccentric. That too, it is a woman. Think of calcified fibroids. Fibroids can calcify in various ways. Punctate, nodular, arc-like, calcific rims, or a lump of homogeneous type of calcification. This is calcified fibroid. And then, as I said earlier, various types of calcifications you can see in the fibroids. Here, nodular type of calcifications scattered. Whereas here, you also see densities, but if you look closely, they resemble teeth. There is a central pulp, and there are incisors and molars. And whenever you see teeth, think of a dermoid, particularly in women, Ovarian dermoid or a teratodermoid. And then here, AP and lateral views, you see fetal bones, the collapsed fetal bones. This is what is called Lithopedian. See, the child or the fetus is dead long time ago, silently, and the patient comes with a mass, the woman, not knowing that there is a dead fetus long time ago. It's not just occurred recently. And then sometimes you see gas in the pelvis. It's not gas in the bladder because bladder you can see, rectal gas you can see, bladder is, you can see just besides the rectum as a density, and above that there is gas. This is gas-infected uterus after delivery. Gas organisms, E. coli can produce, or gas-producing bacilli can be there. It is quite dangerous for the patient. And then years ago, we used to do what we call pelvimetry, to know the dimensions of the pelvic outlet, inlet, midlet, and find out whether there will be normal delivery or difficult delivery, or if there is a cephalopelvic disproportion, whether she needs a cesarean section. On the other hand, occasionally, prolonged delivery may produce fetal death. So you see the cranium, you identify the fetus, and placenta previa, there is a marked distance between the filled bladder and the uterine wall or the head of the fetus. There is a thickness, we called it placenta previa, placenta intervening between the head and the uterine outlet. A woman, obviously, because there are breast shadows, but there are some calcific rounded shadows, rim only calcified, bilateral symmetry. Today, with the advanced techniques, women wanting more and more impressive to the people, they get breast implants. These are breast implants calcified, silicone implanted. And then, of late, even in India, earlier when we were students, carcinoma of the breast is not that common. And today, it has become, particularly in urban areas, it has become very common, and so mammography should be done in order to detect early changes, not necessarily cancer, but any early changes in the mammary gland, and say fibroid adenoma, commonly benign, can be observed. And there are various methods of mammography. Conventional technique is out today. There are mammographic machines, and zero mammography we used to do long time ago, and then ultrasound to find out if the lump is cystic or solid, and the soft tissues are infiltrated, CT, MRI, these are various methods of mammography. Here, look at the dense nodule surrounded by lucency, fibroid of the breast. There is no infiltration to think of malignancy. On the other hand, the nipple is puckered, withdrawn, and there is a mass with spicules, definitely carcinoma of the breast. Frankly, today's checkup mammograms after the age of 30 or 40 is mainly to detect any abnormality. Is it normal or abnormal? And if it is abnormal, there are certain radiographic criteria, speculation, microcalcification and all that, and to find out the site where a core biopsy can be taken so that a definitive diagnosis can be made, or the cancer can be ruled out. Pelvic pneumography. See, today with the various imaging methods, we have been able to see the uterine cavity by hysterosalpingogram, by ultrasound, most of the fibroids and ovarian disorders. You can see even carcinoma of the cervix. By early MRI, you can see changes in the cervical area. But earlier, in order to identify the organs, conventional APU was not enough, except to diagnose the pregnancy. Woman is pregnant or some other calcification. Otherwise, it's not, did not play much role to study the ovary, the tubes, and the uterus, or other extragenital structures. And this is pelvic pneumography. Inject air, atmospheric air, and tilt the patient so that all the air goes into the pelvic cavity and study. This is what you see. Beautiful. The one on the right side, you could see the uterus outlined, the tubes, and the bilateral symmetrical ovaries surrounded by gas lucency. Classical, normal appearance. Sometimes the uterine cavity cannot be seen. That's why they used to inject contrast so that you could see the uterine cavity. Look at the one on the left-hand side, lower, small ovaries. And absence of uterus is important. Then came hysterosalpingography. That is, hyster means uterus, salping is trumpet, graphene is to write, hysterosalpingography. In other words, contrast study of the uterus and the tubes. What are the indications? Any developmental abnormality. For example, is there a uterus? Is there a cervix? Are there tubes blocked? Congenitally. And then abnormal bleeding, infertility, uterine lesions, tubal lesions, and IUD location, intrauterine device for family planning or whatever location. Sometimes they migrate into the tubes, into the peritoneal cavity, retrouterine space, etc. What are the contraindications? Whenever you suspect pelvic inflammatory disease, you should not do hysterosalpingogram. Pregnancy, you should not do. Active vaginal bleeding, you should not do. Radiation to ovaries is about 75 to 550 million rads. Supposing the patient does not want any radiation, should not do hysterosalpingography. The patient's consent is necessary. Informing the patient that there may be some radiation exposure to the ovaries. What are the developmental anomalies of the uterus? Arcuate type of uterus, septate, bicornuate, didelphys, unicornuate, hypoplastic or infantile uterus. Look at the hysterosalpingogram. The uterus is on one side, only one tube is noted. That means you are injecting only into the cervix of one uterus. There must be another uterus on the left side too. Uterus didelphys. See, double cervix, double cervical canals, and double ureter. Here, it's a nice hysterosalpingogram, nice in the sense the uterus is outlined, the tubes are outlined, and the cervical canal is outlined. But if you look into the uterine cavity and the cervical canal, there is irregularity. It is due to adenomyosis of the uterus and a filling defect in the uterus on the left side. A big filling defect due to fibroids. Fibroids could be intrauterine, intramural, or exophytic. Another fibroid just at the site of the cervix with look at the depression of the uterus. Because of the additions, the right tube is beaded and dilated. Is It's supposed to be due to tuberculosis and adhesions. That's why it is crooked and partially obstructed. Uterine polyp, a filling defect in the fundus of the uterus due to a polyp. Hydrocephalus, marked dilatation of the right salpinx, right tube, due to either obstruction or due to inflammation or infection. As I said earlier, you should not do hysterosalpingography if you suspect pregnancy, but the patient is menstruating, they didn't suspect pregnancy, and then there is a intra-abdominal pregnancy is there. Again, irregularity of the uterine wall due to endometrial hyperplasia. Asherman syndrome. Once you see the curettage and dilatation has become so common, particularly in Indian women. As a sequence of it, you can get some adhesions or some clots. That's what is called membranes, Asherman's syndrome. And then came cross-sectional imaging, plain radiography, hysterosalpingography, pelvic pneumography. Nobody does pelvic pneumography anymore. Hysterosalpingography is done occasionally. Cross-sectional imaging, ultrasonography, computer axial tomography, magnetic resonance imaging, SPECT, the radionuclide study, PET scan, positron emission tomography. Prenatal diagnosis of congenital anomalies. Dandy-Walker cyst, look at the skull of the fetus, look at the tentoria, a huge anechoic lesion in the posterior fossa due to Dandy-Walker cyst. Hydrocephalus, you can measure the size of the ventricles and septum pellucidum, from the septum pellucidum. Fetal hair drops, double density of the head, edema of the scalp, short limbs. There are so many lesions of dwarfism and short limbs, so many conditions. This is one of them. And then uterine device, you can see echogenic shadow in the center of the uterus. You can see the bladder above, cross-section of the pelvis. And then fetus, the early fetus calcification of the head. See the echoic lesions in the skull area. Early diagnosis of fetus. And then these are scattered lesions by ultrasound, fibroid of the uterus. The importance of ultrasound is in fibroids. On plain film, you may not see any calcification. Whereas ultrasonography is highly sensitive to echogenic lesion. Early calcification you can detect. Tubo ovarian mass, an anechoic lesion with some echoes. Tubo ovarian abscess. Classical of a ovarian dermoid. Why classical? They are echogenic ball-like masses. It's all fat and contains hair, sometimes gelatinous material. These are balls. Very diagnostic of a ovarian dermoid or teratodermoid. Ectopic pregnancy, fetal pole, small fetal pole you could see on the left side. Papillary cyst adenocarcinoma, cystic lesion is there, anechoic lesion is there, and then at the bottom there are projections, echoes. Papillary cyst adenocarcinoma of the ovary. Sonohistography, that is endometrial cavity is distended with saline, and then to distinguish the focal from diffuse endometrial pathology. And then focal is less than 25% of endometrial surface. If it's more than 25%, say 50, 60, then you know it is a diffuse type of endometrial pathology. This is important for decision making. Then computer tomography. Only thing is, computer tomography gives risk of radiation. But we have to balance. Is the risk more important or the diagnosis more important? If the risk is less, if the diagnosis is more important, go ahead. High sensitivity, but low specificity. Again, you notice fibroid of the uterus with the degeneration in the center, low attenuated areas, compressing the bladder. Huge fibroid of the uterus. Again, fibroid degeneration, you could see with compression of the bladder. Ovarian cyst with the solid components looks like a fibroid, but ovarian cyst, huge one, and then in the bottom there is a hyperdensity, and the top there is cystic structure. Usually you think of malignant nature of the ovary. Mole, hydrated form, mole. You see the fluid level, classical. Several variations. Calcific densities. Earlier we have seen the fetal skull. Almost here it looks multiple calcification, but in the center also there is apart from the shell, there is a center. There is a tooth calcification, dermoid. Pregnancy, skull bones you could see. Of course, never do to detect pregnancy by CT. That is a no-no. That is immoral and unethical. But the patient does not give history. Partial menstruation, partial bleeding is there. So we think there is a menstrual periods going on. Accidentally you do that. And this is the picture. Infected uterus, postpartum, and then in the center there is gas infection by E. coli. Other gas bacillus organisms can produce this gas. And then tubo ovarian mass, YTB, because there is calcific rim, because in tuberculosis, abscesses, calcification is common rather than pyogenic abscesses. This is a tubo ovarian abscess due to tuberculosis. Endometrioma left ovary, lucent center and a peripheral density, looking like an abscess, but it's an irregular endometrioma of the left ovary. Carcinoma of the cervix. Again, early carcinoma you don't diagnose by CT. But CT appearance, if there is a irregular mass with extensive pressure over the bladder, CT, carcinoma of the cervix may be suspected. Here, grading, invasion of the bladder, not only confined to the cervix, it is invading the bladder. Sometimes you can see the pelvic nodes also. Again, gas infection. You see multiple gas lucencies. Could be infection. Ovarian cyst, small ovarian cyst on your left side, which the arrow points out. Again, carcinoma of the cervix with distension of the uterus, and there is some blood in the center of the uterine cavity. Endometrial carcinoma, the entire uterine cavity is distended, irregularities are there, irregular densities, lucencies, endometrial carcinoma. Ovarian carcinoma, note the mass, and then that mass, there are stellate pattern in the center, invasive type of ovarian carcinoma. Now we go to MR, magnetic resonance imaging. Fortunately, these resolutions high in MR. Multiplanar imaging is possible, not affected by CAS, no streak artifacts, vessel involvement is better seen. Of course, Doppler study is there, but even then, without ultrasound, you can see vessel involvement, tissue characterization. Most important of all, ladies and gentlemen, there is no radiation. Although it is very costly, but then depending upon the indications, one should look into MR in women's imaging for various disorders. The sagittal view of MRI, look at the bladder, pubic symphysis, uterus, and behind the uterine cavity, cervix, and behind the uterus, the rectum. Beautifully demonstrated. The resolution is so high and so nice, you can display the normal anatomy, and any deviation from the normal, you can early on identify. Again, uterus, there is some muck in the uterine cavity, that is carcinoma or pyometra. Clinically, you should diagnose. Now, in women, there is a silent epidemic of osteoporosis and also occasionally osteomalacia in certain communities. How do you diagnose osteomalacia, particularly in young women? Generalized lucency of the bones, increased density sometimes due to osteoid excess, ground glass appearance, that is, you can't differentiate the cortex from the spongios. Everything is a ground glass AC appearance. Osteoid seams are called loser zones, translucent areas, which may be mistaken for fractures, but fractures generally do not occur transversely. And because of the softening of the bones, osteomalacia, maleic bone, that's why you get deformities. As I said earlier, there is lack of differentiation between the cortex and sponges. Endosteal and periosteal new bone formation may be seen. Fractures, either traumatic or pathological or common, or even stress fractures, and eventually it leads to secondary hyperparathyroidism. A classical case of osteomalacia, but it's not acute osteomalacia. In the sense, there is deformity of the pelvis, a triangular type of pelvis. There are looser zones, but there is some callus formation. Already some looser zones or osteoid seams are already pseudofractures, already healed. That's why in the ischiopubic junction you find callus formation. This is acute osteomalacia. Most of the patient is about 18 years old. Look at the deformity of the pelvis because of the softening of the bones. Again, fractures, real fractures and deformities of the necks of the femora has occurred, osteomalacia. Cone view of the symphysis pubis to show the pseudofractures or the osteoid seams or the looser zones. Often they are bilateral and symmetrical. Again, another case of pelvis deformity with pseudofractures at the necks of the femora and deformity of the pelvic bones, osteomalacia. And often it is also reflected in the limb bones. Frankly, most of it you can see in the axial skeleton, including the pelvis, ribs, but occasionally it may extend into the limb bones. See on your left, the so-called pseudofractures or looser zones in the scapula. Even the pulsation of a transscapular artery can produce this loosened zone. What is this loosened zone? This is deficient mineralization. The osteoid is there. That's why osteoid seam, we call it osteoid there, but it's not mineralized because of the constant pulsation of the artery. Similar changes are also noted in the elbow and femur. Frankly, it's not just women's imaging, but in clinical medicine, if you want to practice scientific medicine and evidence-based medicine, imaging is